Hello everyone. So today's our topic of discussion is urinary incontinence. Okay, so let's start it. So this was a question which was asked in FMG December 21 and NEET PG 21. Okay, same question was asked in both exam. The lady passes urine while coughing or laughing. On examination, there is second degree uterine prolapse and cystocele. What this abnormality is? Okay, now the main problem is that this lady is passing the urine while this lady is coughing or laughing. Okay, now many students confuse this condition of incontinence with fistula. Okay, so I want to discuss this topic: what is fistula and what is incontinence, and with what history the patient comes. Fistula is that a fistula has been formed between the urinary tract and the genital tract. For example, if this is urinary tract and what this is the genital tract, so a communication has been um, formed, a tract has been formed between them. So in the case of the fistula, the patient will complain that urine is coming out of the vagina. Okay, because this urine will then come into the vagina. So complaint of the patient in fistula is that the urine is coming from vagina. Whereas what is incontinence? Incontinence is that the urine is coming itself from the urethra. Urine is coming from urethra, but it is coming at inappropriate time. At urine is not coming at appropriate time. Not coming at appropriate time. Okay, now what do we understand by not coming at appropriate time? So you all know that we have a voluntary control on our micturation. Now if because of that control we are able to pass the urine whenever we are in the loo, right? Now if that control or the physiology of the micturation is affected such way that we are able to pass urine without the control, then that is the urinary incontinence. So urinary leakage in incontinence is always from urethra. It is not from genital tract. The urinary leakage from genital tract is seen in fistulas. Okay, so these people, they always give a one option of fistula for those who are not clear with this concept. Okay, so in the question of the incontinence or inappropriate passing of the urine or leaking of the urine, you are never going to mark fistulas. Okay, and in the question of fistulas you are never going to think that it is a case of incontinence. Okay, so now here the lady was passing the urine, and that inappropriate time was that when the lady had cough or when the lady laughed. So you all know that the answer to this question is stress urinary incontinence. Okay, but now we will discuss all the incontinence here. Okay, so what is stress urinary incontinence? That urinary incontinence means urine leakage at appropriate time, at not at urine leakage, not at the appropriate time. Okay, so when this urinary leakage is associated with stress here doesn't mean the mental stress. Stress here means the increased abdominal pressure. Okay, so whenever this lady's abdominal pressure is increased, then this lady passes the urine. And when is abdominal pressure increased? Whenever we cough, whenever we laugh, whenever we perform Valsalva maneuver, or whenever we blow a balloon, and all this condition, the abdominal pressure it increases, and this lady passes the urine, and that type of the urine leakage is known as stress urinary incontinence. Now what is urge incontinence? As the name is telling, urge means whenever the lady has a feeling of that my bladder is filled, before going to the loo the lady micturates, urine leakage occurs. Okay, so if the urine in leakage is simultaneously with the urge, then that leakage is known as urge incontinence. Okay, what is overflow incontinence? In overflow incontinence, what happen is that uh, the bladder is the urethra is obstructed due to a mass in the pelvis. Okay, due to mass in the pelvis, the urethra is obstructed, and then that and from that obstructed urethra, the urine cannot come out. Okay, then that urine, what happens is that that bladder, urine gets filling in that urine get filled in that bladder, and then that bladder get over distended, and then after that bladder get distended, then urinary leakage occurs. Okay, then that is known as overflow incontinence. Okay, now what is neurogenic bladder? Neurogenic bladder means damage to sacral nerves. Okay, so what is now neurogenic means due to some nervous system problem, the incontinence is there. Now due to some problem, the sacral nerves which are supplying the bladder, they get damaged. So now the lady doesn't know when the bladder is filling, when she need to micturate. So then again this lady suffers a problem of incontinence. So let's study the basics of micturation now. Okay, now you all know that on the micturation there is involuntary control and the voluntary control. Both controls are there. When I'm saying involuntary, it means autonomic nervous system, and when I'm saying voluntary, it means the motor nervous system. Okay, so let's see the physiology of the micturation. Now this is the bladder. This, when now there are two phases. One phase in which this bladder is getting filled. Okay, let's see. Now this bladder is getting filled with urine. Okay, now at this stage, the external, this is external urethral sphincter. Okay, the external urethral sphincter is contracted. Okay, so that once the bladder get filled up till 150 ml, then only the brain will get stimulus that the bladder is filled, and then we will micturate. Okay, so up till 150 ml, this external urethral sphincter, this is external urethral sphincter, it is in the contracted stage, and this is maintained by the sympathetic nervous system. The external urethral sphincter is maintained in the contracted stage by the sympathetic nervous system, and that are alpha adrenergic receptors are there. Okay, so norepinephrine is released and they act on alpha adrenergic receptor, and they maintain the external urethral sphincter in the contracted stage. Now when the bladder is filled, then the brain gets the stimulus that the bladder is filled when the level is more than, when the urine volume is more than 150 ml. Okay, now then the brain tells us that now and then we get the urge to micturate. Okay, now we have to go to the loo. Till then, we give the brain the stimulus that we give the brain the action that now we are not in loo. When we are going to the loo, we will micturate. So when we are in the loo, the sacral nerve, that is the voluntary control. Okay, sacral nerve from the motor nervous system, it gives the stimulus to the brain. Okay, key, now we are in the loo and now we can micturate. Then the brain activates the parasympathetic nervous system on the, and then the parasympathetic nervous system acts on the cholinergic receptor. Okay, so now the receptors which are responsible for relaxing the external urethral sphincter is the cholinergic receptors. Okay, now the cholinergic receptors, they act and they relax the external urethral sphincter, or you can say they open the external urethral sphincter, and then the urine comes out and we micturate. Okay, so this is the basic physiology of the micturation. So here we learned that during the bladder filling phase, what is happening is the alpha adrenergic receptors, they are making the external urethral sphincter in a contracted stage. Okay, and the in during the micturation, the message via the sacral nerve, the motor nervous system, gives them activates the parasympathetic nervous system, and this parasympathetic nervous system via the cholinergic receptors, it relax the external urethral sphincters, and we are able to micturate. So this is the normal physiology. And one thing I would like to tell you here is that this external urethral sphincter is nothing but levator ani. Okay, and this levator ni, it has two tones. One is the its nerve innervation. Its tone is maintained by nervous system innervation as always. And this muscle also has the estrogen tone. It means that the tone of this levator ni is also maintained by estrogen. Okay, so now you all know that at this estrogen tone goes after menopause. So after menopause, because this levator in a estrogen tone is gone, so almost every lady suffers from urinary incontinence. Okay, so stress urinary incontinence is, now we are studying the main topic of today's discussion, stress urinary incontinence. So stress urinary incontinence is nothing but the what is the etiology is that this external urethral sphincter or the levator ani has got weak. So now what will happen when this will become weak? So this is the normal stage. This weak external urethral sphincter was able to sustain the pressure which the normal filling bladder was giving. Okay, so now this is able to maintain the pressure which the normal filling bladder was giving, but this is not able to maintain the pressure which the increased abdominal pressure gives. Okay, so it is not able to maintain that pressure which the increased abdominal pressure gives. Okay, so what happened, as you are seeing that in this this is external urethral sphincters. So when this external abdominal pressure is increased abdominal pressure, now this external urethral sphincter goes down. Okay, and when this goes down, this urethra, it gets open up. Okay, and when it opens up, the urine leaks, because this now levator ani or the external urethral sphincter is weak. Now that is what it is, stress urinary incontinence, that external urethral is weak, or we can say that due to the weak external urethral sphincter, this urethra becomes hypermobile. Okay, so it is this. So what are the risk factors which increase? First, I already told you, age. Then the parity. Whenever the woman is pregnant, the fetus and the contractions, they give a lot of pressure on the levator ani. So with every parity, the levator ani gets weak. Same is the condition while in the obesity. So increased abdominal pressure of the obese person weaks the levator ani, and same is the condition in weightlifting and cough. Okay, now let's see what are the test, or what are, how we can evaluate a patient of stress urinary incontinence. So when a patient comes into us to the OPD giving the complaint, now we are in the mind with the diagnosis that this patient is of stress urinary incontinence. We have ruled out the risk factors in the history. Okay, now we will want to evaluate whether the complaint said by the patient is true or not. So we will examine the patient by putting the patient in the lithotomy position, and then we will ask that patient to cough. Now if on coughing the urine leakage is there, then it is a true case of stress urinary incontinence, and this is this test is known as stress test, that is increasing the stress, the urine leakage. Okay, then next is the Q-tip test. What is Q-tip test? For example, this is a case when abdominal pressure is increased. Now here we put a stick on which upper part is the cotton swab is there. Okay, so this type of stick and swab at the upper end we put Q-tip. Okay, this is known as Q-tip. In the case of the stress urinary incontinence patient, when this patient will increase the abdominal pressure, as you're seeing here, the urine will leak, and this hypermobile, due to this hypermobile urethra, this will makes a 30-degree angle. Let me show you. So this will, due to the leak, due to the weak external urethral sphincter, this will make an angle like this. Okay, so if this angle is more than 30 degrees, so it tells that this is a patient of urinary incontinence. Now another test is the Marshall-Bonney test. What is Marshall-Bonney test? Look here into the camera. Normally how we do PV, we insert two fingers vertical, one above the another. Okay, but in the Marshall-Bonney test we are going to insert two fingers transversely into the vagina, and we are going to support the levator ani. Now when we are supporting the levator ani, the weakening of the levator ani is now strengthened. So now there will be no urinary incontinence on increasing the abdominal pressure. Now after strengthening the external urethral sphincter, now we will ask the patient, now you cough. Now if on strengthening the urinary sphincter or levator ani, if there is no leakage, so we come to the confirm that this is the case of stress urinary incontinence, and in this patient there was weakening of the levator ani or external urethral sphincter. Okay, now how we are going to manage this case of stress urinary incontinence? Treatments are asked. Okay, so first of all, if the patient is obese, then we will ask the patient to reduce the weight. Okay, next is the Kegel exercise. What do you mean by Kegel exercise? We will train the patient. We will ask the patient, when we will put the finger in its vagina, and we will ask the patient to tighten the tighten the finger by the pelvic muscles. Okay, so this and we will ask the patient to count up till 10. Okay, in on its own. So now up till 10 the patient will be tightening. So for example, this is the vagina, I have put one finger or two finger in the vagina, and this is vagina. Now the patient will tighten it by pelvic muscle. Now by this the levator ani, by this exercise the levator ani will strengthen. Okay, these are known as Kegel's exercise, and thus the patient has to practice thrice a day, you can say. Okay, so this is the conservative management of the stress urinary incontinence. Then is the alpha adrenergic agonist. You have seen that external urethral sphincter is maintained in its contracted stage by the alpha adrenergic receptor. So we give the medications that the alpha adrenergic agonist. Okay, then we can also give SSRI, duloxetine, and you know that the levator ani tone is also estrogenic tone. So we are going to give this patient topical estrogen also. So these are the medications which we can give to the patient of stress urinary incontinence. Now let's see what all surgery we can do. So all the surgeries which are done in the patient of stress urinary incontinence are the slings. So you know that here the sphincter goes down with increase in the abdominal pressure. So what we are going to do here is that we are going to put here a sling. Okay, so even if the levator ani goes down, this sling can function and prevent the stress urinary incontinence. So these are the surgeries of stress urinary incontinence. So slings. Okay, one is the Callis stitch. So what is Callis stitch? Callis stitch means we apply a stitch there. Okay, here we apply a stitch and fix the urethra. Okay, in the here. Okay, then next surgery is the TOT or TVT. In the TOT means trans obturator tape. Here the tape is come inside the come near to the urethra via the obturator foramen. Okay, so this is trans obturator tape, or TVT is transvaginal. If the tape or that sling goes through the vagina, then it is known as transvaginal tape. So these are one of the best surgery these days. They have got very good rate and they are done as a OPD procedure. Okay. Okay. So the other surgeries which were done previously is Butch suspension. These are the abdominal surgeries, or MMK, which is Marshall Marchetti Krantz operation. These are the two abdominal surgeries. Okay, now let's learn about the urge incontinence, last topic of the day. What is urge incontinence? Urge incontinence means, you just look here. What here we studied was that when a bladder is filling in the external urethral sphincter is in contracted stage and this bladder was relaxed. Okay, now what if this bladder contracts during the micturation? Bladder, or you can say bladder muscle, the name of the bladder muscle is detrusor. What if this bladder muscle get activated early? It get activated early. Okay, what if this bladder muscle get activated early? So before 150 ml only, it will tell the brain ki the urine has been filled, right? Are you getting my point? In the bladder filling stage, the bladder muscle or the detrusor muscle is relaxed. That is why the bladder was filling. Okay, and in the maturation phase the bladder muscle contracts. Okay, so what if, and this bladder muscle contracts at 150 ml only, right? You know that. Now what if this bladder muscle gets hyperactive? Then it will lead to the stage of urge incontinence. So 150 ml से पहले ही जो है उसको अर्ज हो जाएगी. Patient will suffer the urge before 150 ml itself, right? Before 150 ml the patient will get the urge, right? And the because that detrusor muscle is hyperactive, so now that will lead to urge incontinence. So what is the reason of the urge incontinence? Detrusor muscle overactive. And when that detrusor muscle get overactive, in the case of UTI, in the case of diabetic mellitus with vasculopathy, or whenever there is a nerve damage. Okay, so when the detrusor muscle gets overactive, yes. So these are the three pathologies when the detrusor muscle gets overactive. Okay, so it gets overactive in UTI, diabetes mellitus with vasculopathy. So whenever a patient has UTI, the bladder muscle gets active. In vasculopathy also the bladder muscle gets active, and the nerve damage also the bladder muscle gets active because nerve has damage. So here the treatment is bladder training exercise, not the pelvic strengthening exercise. Bladder training exercise. In the bladder muscle overactive, bladder training exercise are given. Okay, don't confuse it. Okay, and here the treatment of choice is anticholinergic, because here the anticholinergic was not only relaxing the external urethral sphincter, but they also make the bladder muscle to contract. So here the treatment of choice is anticholinergic, which are tolterodine, oxybutynin. Okay, and here the surgery which we do is cystoplasty, which means that operating that whole operating the whole bladder, or we do urine diversions. We divert the urinary micturation tracts. Okay, urine diversion. So this was about the urge incontinence. So last but not the least, this is a question which was asked in AIMS May 18 about this. While performing Birch operation, Birch colpo suspension, which we do in stretch urinary incontinence. Okay, there was significant bleeding in space of Retzius. So now what is Retzius? Retzius is a space which is behind the rectus abdominis. Okay, the source of bleeding was not visualized. What is the next step? So you should know one thing, that first of all, that the rectus behind the rectus abdominis is the space of Retzius. Okay, so while we are doing Bruch operation, injury can happen there, and this Retzius space doesn't contain any main artery, doesn't contain any main vein. It's a just small centorni venous plexus, very small. So this bleeding simultaneously only it gets solved. Okay, after 4 or 5 minutes, this bleeding gets stopped, because it's a very small venous plexus in the space of Retzius. So the option called vascular surgeon is not necessary, because the vascular surgeon, we only call vascular surgeon when there is major aorta bleeds, something like that. Okay, then generalized suture in the bleeding area. Generalized suture we never give in the bleeding area. Okay, place a drain. No, we will not place a drain, because we know that bleeding will stop after few seconds. Lift endopelvic fascia and put finger in vagina. This was correct, because when we will lift the endopelvic fascia, we will approach the space of Retzius. We can also approach this via vagina. Okay, so when we will lift the endopelvic fascia, we will approach this space of Retzius, and then when we will put the finger, the plexus bleeding will get controlled. So answer was this. This was very difficult question, but still, as it is a PYQ of the last 5 years, so I have put it here. Okay, so that was all about the urinary incontinence. See you soon in the next class. Till then, goodbye.